Hello everyone, I am Dr. Saida Khatija Fatima, Assistant Professor in the Department of Pathology, and I'll be talking about bone tumors in bones and joints pathology today. Bone tumors may present in a number of ways. The more common benign lesions are often asymptomatic incidental findings. Many tumors produce pain or slow growing mass. In some circumstances, the first hint of a tumor presence is a pathological fracture. Radiographic imaging studies have an important role in diagnosing these lesions and to provide exact location or the extent of tumor, but ultimately it is the definitive biopsy which helps in a definitive diagnosis. The bone tumors are classified according to the normal cell or the matrix they produce. Lesions that do not have normal tissue counterparts are grouped according to their clinicopathological features. Benign tumors are more common than the malignant ones. The bone-forming tumors are also called as the mineralized woven bone-forming tumors or unmineralized osteoid-forming tumors all fall under this category. So the bone-forming tumors are osteoma, osteoid, osteoma, osteoblastoma and osteogenic sarcoma. So the osteo word means bone formation. Cartilage-forming tumors is chondroma, osteochondroma, chondroblastoma, chondromyxoid fibroma, chondrogenic sarcoma. Fibrous tissue-producing tumors are called as fibrogenic tumors, and in this mainly we will be covering non-ossifying fibroma. Unknown histogenesis. So these are the ones in which the cell of origin is not yet established. So giant cell tumor, very common tumor, very popular tumor, falls under this category. Ewing sarcoma and adamantinoma all fall under this category. Osteoma is a benign tumor composed of woven and lamellar bone. So woven bone is the unmineralized bone and lamellar bone is the mineralized bone. So it is a mixture of both the bones and it is present usually on flat skull bones. It can cause sinus obstruction, irritation to the brain as well. A meningioma can induce an osteoma in overlying bone rarely. Osteoid osteoma. So osteoid osteoma and osteoblastoma both are the benign tumors arising or benign bone forming tumors, and they have identical histological features, but osteoid osteoma and osteoblastoma differ in size, site of origin and symptoms. So size, if you compare the size, osteoid osteoma is usually not more than 2 cm in diameter. It will not be more than 2 cm, but osteoblastoma will be more than 2 cm. So osteoid osteoma patients will be in teens and 20s. 75% of the patients will be less than 25 years of age. It can arise in any bone, but it has a predilection for the appendicular skeleton. 50% of the cases involves the femur or the tibia, long bones of the femur and tibia, where they commonly arise from the cortical bone. Now the main characteristic feature of this is the nocturnal pain. In spite of the small size, they present with severe nocturnal pain which will be relieved only by non-steroidal anti-inflammatory agents like aspirin. The pain is probably because of prostaglandin E2, which is produced by the proliferating osteoblasts. Larger tumor of same kind is called as osteoblastoma. So this is a radiographic picture. Now in this you're seeing a central translucent area which is called as the nidus and surrounded by a reactive bone which is isodense. So the round radiolucency with central mineralization present represents the lesion and is surrounded by abundant reactive bone that has massively thickened cortex. So this central radiolucent area is called as the nidus. Again, this nidus will have a central mineralization present. So this is how osteoid osteoma or a osteoid osteoblastoma will look like. Main difference is just the size of both the lesion. So this is the nidus part, and this is the radiodense part of the, or the excess growth of the cortex of, or the reactive bone, which is seen around the nidus. So what exactly is the nidus composed of? So this is the nidus, which is concentrated here in this picture. So the nidus is composed mainly of, so what you're seeing here in the nidus of osteoid osteoma is randomly interconnected trabeculae. This thin pink eosinophilic structures are trabeculae. This is relatively thin than the normal lamellar bone. So that's why this can be called as thinned out trabeculae. So this will be rimmed by osteoblast. So can you see this thin trabeculae lined by some cuboidal to flattened cells? So those are nothing but osteoblasts. A single layer of osteoblasts will be there. Prominent rimming will be there. You can easily identify the rimming. And intervening stroma will be highly vascularized. So here the red spaces which you are seeing filled with RBC is nothing but the proliferating capillaries lined by flattened endothelial cells. So these are the capillaries. So highly vascularized loose connective tissue with many dilated and congested capillaries, and benign cytological features of the osteoblast will be there. So like this we can differentiate. Later on I'll tell you the difference between osteosarcoma and osteoid osteoma. So depending upon the cytological features as well as the rimming of the osteoblast, we can easily rule out osteosarcoma in this. Osteosarcoma is defined as a malignant mesenchymal tumor in which cancerous cells produce bone matrix, that is osteoid. It has bimodal age distribution, that is 75% occur in patients younger than 20 years of age. Again, osteosarcoma can be classified as primary or secondary. Primary means there is no underlying bone disease, and secondary is a pre-existing disorder, whether it is a benign tumor or Paget's disease or bone infarcts or previous radiation can be present. Those are called as secondary osteosarcomas. So here a smaller second peak occurs in older adults who frequently suffer from these. In adolescents, and about half of them arises in the metaphysis around the knee, either in the distal femur or proximal tibia. In persons over the age of 25, incidence in flat bones and long bones is almost equal. So these are the major sites of origin of osteosarcoma. 8% arise in the facial area, 10% in the humerus, 15% in the hip joint, and 60% in the knee joint. So clinically, an osteosarcoma typically present as painful and progressively enlarging mass. Sometimes a sudden fracture of the bone is the first symptom. Grossly, we see a grey-white tan tumor extending from the medullary cavity into the metaphysis, and also it can extend into the adjacent soft tissue by eroding the periosteum. Areas of hemorrhages and cystic spaces can also be seen. As this is arising from the medulla, it is called as intramedullary osteosarcoma. So based on site of origin, we can say classify the osteosarcoma into three types: intramedullary, intracortical, or the surface. The intracortical is also called as juxtacortical, and surface is called as periosteal. So here juxtacortical arises just beneath the periosteum and adjacent to the cortex. It can also invade the adjacent soft tissue. whereas periosteal arises just adjacent to the periosteum. Again, based upon the histological features as well as some gross differences, osteosarcoma can be classified as chondroblastic, osteoblastic, and telangiectatic. So it is the telangiectatic that will have typical gross feature of dark brown hemorrhagic area. Again, this will show an extension into the adjacent soft tissue. Now the radiographic feature is very important. We should remember that always before diagnosing a bone tumor on biopsy, we should correlate with the age of the patient, site of the tumor, and the radiographic feature, because all these will give a hint to the diagnosis. So the characteristic radiological feature of osteosarcoma is a large destructive lesion. It can be osteolytic lesion. You can see translucent areas, as well as osteoblastic lesion. So a mixed type of osteolytic osteoblastic lesion will be there. So here what happens is there will be extension into the adjacent soft tissue. So as the tumor extends into the soft tissue, it will lift the periosteum. This lifting of the periosteal surface, the margin of the cortex, will create an angle here that is called as Codman's triangle. So the triangular shadow, this is the triangle created. Okay, all three sides, can you see? So this is the triangle created or triangular shadow created between the cortex and the raised end of the periosteum, and this is the tumor. So the triangle is called as Codman's triangle. This is characteristic of osteosarcoma, but it is not diagnostic. If present, it gives a great clue to the diagnosis. So this is a radiograph showing distal femoral osteosarcoma with prominent bone formation extending into the soft tissue. Periosteum has been lifted and has laid down a triangular shell of reactive bone known as Codman's triangle. Now, as I said, histologically also they are osteoblastic, chondroblastic, fibroblastic, telangiectatic, small cell and giant cell osteosarcoma. So what is osteoblastic? Means bone forming. So here we see an osteoblastic type of osteosarcoma with osteoid formation, that is bone formation. Osteoid is nothing but a bony matrix. So here you can see lace-like pattern of the bony osteoid. The pink color one is the bony osteoid. The characteristic feature you are seeing here is this osteoid is not rimmed by the osteoblast, as which we saw in osteoid osteoma. So there is no rimming of osteoblast and they have a characteristic lace-like pattern. This might be confused with the hyphae. So hyphae like thin lace-like osteoid will be there. And the adjacent intervening tumor cells will have high-grade anaplastic spindle cells with large hyperchromatic nuclei. So this is a characteristic osteoblastic type of osteosarcoma. Chondroblastic will have some cartilaginous component or chondrocytes in between the lace-like osteoid, and fibroblastic will have fibrous tissue or fibrous tissue cells. Telangiectatic will have dilated vessels, the one which we saw in gross. Microscopically, they will be dilated and congested vessels in telangiectatic type. Small cell will have small cell component, round tumor cells, and giant cell will have a giant cell component. So this is again the osteoid which is seen here. Magenta colored osteoid without rimming of the osteoblast, fine lace like, resemble like a fungal hyphae. But here the tumor cells are the malignant tumor cells, which is showing very high grade nuclei. Can you see the variation in the size of the nuclei and the pleomorphism? Some are round to oval, some are elongated, some are binucleated here with prominent nucleoli and mitotic figures. So all this constitute osteosarcoma. A brief mention about the genetics of osteosarcoma is that there are mutations in tumor suppressors and oncogenes like retinoblastoma gene, which is inactivated. So this is a cell cycle regulator gene. So this leads to cancer formation. Then TP53, which is a cell cycle, again cell cycle regulator or the guardian of the genomic integrity. So the loss of or mutation in this gene will lead to Lee-Fraumeni syndrome, which causes multiple cancers in different organs. INK4A is inactivated again. So this is again a gene that encodes P16 and P14. These two are responsible for regulation of the cell cycle, and they also promote the function of TP53. If lost, if INK4A is inactivated and if P16, P14 are lost, then TP53 will lose its function as well. Then MDM2 and CDK4. So these are again cell cycle regulators that inhibit the P53 and RB function respectively. So these are overexpressed. Overexpression of MDM2 and CDK4 will lead to low-grade osteosarcomas. Now coming to the cartilage-forming tumors, osteochondroma is the most common cartilage-forming tumor. Majority of the primary bone tumors are cartilaginous tumor. So benign cartilage capped outgrowth will be there, that is attached to the underlying skeleton by a bony stalk. Osteochondroma is also known as exostosis, that is the cartilage protrudes out of the skeleton by a bony stalk. So this is relatively common lesion and can be solitary or multiple. The remainder, like 85% is solitary, and if it is multiple, it comes as a part of multiple hereditary exostosis syndrome, which is an autosomal dominant hereditary disease. Multiple becomes apparent in childhood, whereas solitary are usually not diagnosed until late adolescence. Men are affected 3 times more than women. They arise from the metaphysis near the growth plate of long tubular bones, especially the knee. Occasionally they develop from pelvis, scapula, ribs, and in these sites they are frequently sessile and have short stalks. Clinically, osteochondromas present as slow-growing mass which can be painful if they impinge on a nerve or if the stalk is fractured. In many cases, they are detected as an incidental finding. In this radiograph, we are seeing that an osteochondroma is protruding out with a stalk posteriorly to the bone in the ankle. And the end is often covered by a cartilage, so the end is radiolucent. These lesions occur near a joint but point away from the joint. They can be sessile or pedunculated. In this case, this is pedunculated and connected by a stalk. The size can range from 1 to 20 centimeter. It will have a cap of cartilage. Mostly hyaline cartilage will be there. Fibrous elastic cartilage is very rare in osteochondromas. So bluish hyaline cartilage will be there as a cap, and there will be a stalk. So the cartilage will undergo enchondral ossification and lead to bone formation. This bone formation will continue as a stalk of the osteochondroma. This stalk will be in continuation with the cortex of the host. So that there will be a continuity between the stalk of the osteochondroma and the cortex of the host. Coming to the germline mutations which is present in osteochondromas, it is the EXT1, EXT2 genes which are affected. So there will be loss of function mutations in these genes. So what are these genes responsible for exactly? These genes encode enzymes that synthesize heparan sulfate glycosaminoglycans. So heparan sulfate glycosaminoglycans, if they are abnormal or if they are reduced, that will prevent normal diffusion factor of Indian hedgehog. What is Indian hedgehog responsible for? It is a local regulator of cartilage growth. So basically all these mutations in the EXT1, EXT2 gene is causing disruption of chondrocyte differentiation. Okay. So it will just affect the cartilage growth as well as the skeletal growth. Coming to the chondromas. So chondromas are benign tumors of hyaline cartilage that usually occurs in the bone of enchondral origin. So mainly they occur in the medullary cavity, where they are known as enchondromas. If they occur on the surface, they are called as juxtacortical chondromas. Enchondromas, like most of them are, they are the most common of the intraosseous cartilage tumors and are usually diagnosed in individuals of 20 to 50 years of age. They also can appear as solitary metaphyseal lesion of tubular bones of hands and feet. Radiographically, you can see circumscribed lesions, circumscribed lucencies with central irregular calcification, and the rim will be slightly sclerotic. Sclerotic means radiodense rim will be there. Cortex will be intact. So there are two hereditary disorders like Olier's disease and Maffucci syndrome, which are non-hereditary disorders which are characterized by multiple enchondromas. Maffucci syndrome in addition will have spindle cell hemangioma, just for the knowledge. So most enchondromas of large bones are asymptomatic. Occasionally they have pain and they can cause pathological fracture. Coming to the pathogenesis, there will be mutations in IDH1 and IDH2 genes in the chondrocytes. So this IDH means isocitrate dehydrogenase. So IDH genes produce this enzyme isocitrate dehydrogenase. This leads to, if there is a mutation of isocitrate dehydrogenase genes, then that will lead to synthesis of 2-hydroxyglutarate, which is a new enzyme. So this 2-hydroxyglutarate is an oncometabolite. Oncometabolite is a product produced by a gene which can cause cancerous changes in the DNA. So DNA methylation is affected by this oncometabolite. So this will cause oncogenic changes or cancerous changes in even in genetically normal chondrocytes. So basically it is producing oncometabolite 2-hydroxyglutarate, which is penetrating into the normal chondrocytes, and it is causing cancerous changes in them as well due to epigenetic changes. Coming to the chondroblastoma, this is again a well circumscribed lesion, mostly occurs in the epiphysis of the long bones, ends of the long bone, like mostly concentrated on the lower distal end of the femur, proximal end of the tibia. It can also occur in the pelvis, ribs and scapula. Chondroblastoma cells usually will have this closely packed, highly cellular area with polyhedral, well-defined outline, and each chondrocyte will have either a single nucleus or multi-lobed nucleus, or single or multinucleated nucleus, or multi-lobed nucleus, or some giant cells. Hyperchromasia will be there, and there will be cartilaginous area in between, hyaline cartilaginous area. So basically blastoma represents immature cells. So whatever chondrocyte we are seeing is an immature cartilage. Then chondromyxoid fibroma. Chondromyxoid fibroma is nothing but a combination of cartilaginous and a fibrous tissue. Chondromyxoid fibroma again arises from the metaphysis of the long bones, and it will have a cartilaginous component and a fibrous component on microscopy. So here you are seeing the cartilaginous component, hyaline cartilaginous component with the chondrocytes, benign chondrocytes in between, and here you are seeing a spindle cell component. So this mixture of chondromyxoid stroma and the chondrocytes, benign chondrocytes and the spindle cells represents the chondromyxoid fibroma. Coming to the malignant tumors of cartilage, chondrosarcomas are the malignant tumors that produce cartilage. They are subclassified into central, intramedullary and peripheral juxtacortical based upon the site of involvement. Now the conventional central tumors constitute 90% of chondrosarcoma. It is the second most common tumor after osteosarcoma and accounts for 20% of primary malignant bone tumor. Majority, like 80 to 90% are low grade malignant. So there will be high grade as well as low grade based upon the histological features, which I will tell. So solitary tumor is common than multiple tumor. If it is multiple, it comes under familial osteochondromatosis and familial enchondromatosis or Ollius disease, which will eventually lead to chondrosarcoma. It occurs in two forms: primary de novo, which is 75%, and secondary, which is in association with syndromes like Ollius disease, Maffucci syndrome, exostosis, and as isolate from the chondroblastoma. It occurs usually in 30 to 60 years of age group, with male more common than female. The central type of chondrosarcoma involves pelvis, ribs, shoulder girdle, vertebrae and sternum. Grossly, conventional chondrosarcomas are large bulky masses. They are made up of glistening grey-white translucent cartilage. Sometimes the matrix will look like gelatinous areas. There will be areas of hemorrhage and necrosis as well. In this particular slide, we are not seeing any calcification, but there can be some spotty calcification will be there. Now this is a chondrosarcoma involving the vertebrae. So on radiological imaging, we typically see a flocculent calcification in low-grade tumor. So here we are seeing a calcified matrix which is appearing as foci of flocculent densities and a reactive cortical bone formation. This represents the low-grade type of chondrosarcoma. Whereas high-grade chondrosarcoma usually show a soft tissue involvement. So what is the difference histologically between a low-grade chondrosarcoma and a high-grade chondrosarcoma is the cellularity, the nuclear atypia as well as mitotic figures. So in the low-grade chondrosarcoma, the cellularity will be comparatively less than the high-grade. High-grade will be hypercellular. It will have more pleomorphism than the low-grade. Pleomorphism of the cells and high anaplastic features in the nucleus, increased mitotic figures, all this, and bizarre giant cells will be there in high grade. This is a typical feature of a low-grade chondrosarcoma showing malignant chondrocytes inside the lacunae. So the chondrocytes will be multi-lobed with prominent nucleoli here, and there will be mitotic figures as well. In this we cannot see, but they can be multi-lobed and multinucleation as well. The matrix will be typically hyaline matrix, bluish in color. The cartilage can infiltrate the marrow space and surrounds pre-existing bony trabeculae. Now histologically, I just name the different types of chondrosarcomas. It is dedifferentiated, clear cell, mesenchymal, and conventional. So here we are seeing a conventional type of chondrosarcoma. Ewing sarcoma comes under the tumors of unknown origin and belongs to the Ewing sarcoma family, which includes primitive neuroectodermal tumor. It is the most common primary bone malignancy in kids ranging from like 5 to 15 years of age, which is most common age group for this tumor. There will be translocation for at 11-22 chromosomes. It is much more common in Caucasians and typically affects the diaphysis of long tubular bones, especially the femur and the flat bones of the pelvis. They are painful enlarging masses and can present at the affected site as tender, warm swellings. Sometimes there will be fever and raised ESR, anemia, leukocytosis will be there. On radiography, you can see lytic picture of the tumor and a periosteal reaction which gives an onion ring appearance. So here it will be like diaphysis of the bone. As you can see here, this is the diaphysis of the bone and this is the periosteal reaction. Here also you can see the onion ring appearance of the periosteum. Grossly, it arises in the medullary cavity and invades into the cortex and the periosteum into the soft tissues. It will be tan white and contains areas of hemorrhage and necrosis. Microscopically, it will have very high cellularity or dense cellularity with scant stroma, and the cells will be of the size uniform small round cells, slightly larger than lymphocytes but more closely spaced. The cytoplasm will be very scant, but the cytoplasm looks clear because the tumor as such is rich in glycogen. So with PAS, you can see the PAS positive nature with magenta colored spots in the cytoplasm. Giant cell tumor is so named because of the histology, which is dominated by multinucleate osteoclast type giant cell, giving the synonym osteoclastoma. It is relatively uncommon benign tumor but locally aggressive neoplasm. It usually arises in 20 to 40-year age group. Pathogenesis is mainly because of the neoplastic cells of giant cell tumor, which are primitive osteoblast precursors. So the histology is dominated by giant cell, but as such the neoplastic cells are not the giant cells but the stromal cells, which are osteoblastic precursors, the mononuclear population of stromal cells, which is neoplastic. And the non-neoplastic osteoclast type of giant cells will also be there intermixed with bulk of the tumor, which consists of mononuclear osteoblastic precursors and mononuclear osteoclast as well. So the neoplastic cells, how do they transform? So neoplastic cells will have rank L, that is rank ligand will be there. This rank ligand will release TNF and interleukin 6 and also SDF1. SDF1 is responsible for recruitment of monocytes. These monocytes migrate from the blood vessels and come to the site of neoplastic stromal cells. Now, neoplastic stromal cell, what they do is they join these neoplastic the monocytes which have migrated to the site will express rank. Rank will join to the rank ligand and transform into osteoclast. Osteoclast can become multinucleated osteoclast or mature osteoclast and will lead to destructive bone lesion. So it is the formation of the osteoclast or osteoclastogenesis because of the rank and rank ligand fusion and a formation of interleukin 6 and TNF by the giant cell tumor neoplastic stromal cell that is causing the destructive or lytic lesion. But the main tumor cells are the stromal cells and not the osteoclasts. So here we see a lytic radiolucent area mostly in the epiphysis of the bones, giving it a soap bubble appearance because of multiple radiolucent areas, and it will be covered by a thin rim of reactive sclerotic bone. Microscopically we see giant cells. We see a lot of giant cells here and stromal cells with areas of hemorrhage. So these giant cells have multinucleation, as well as the stromal cells are again ovoid, uniform in shape. So you cannot exactly differentiate between the neoplastic stromal cells and the non-neoplastic mononucleated osteoclast and the multinucleated mature osteoclast. So basically we cannot identify the tumor cells, but we can say that this is a giant cell tumor. So that's why this was included in the tumors of unknown origin. Sometimes we see necrosis and mitotic activity might be prominent in such areas, and these the nuclei of the multinucleated osteoclast type of giant cells can be 100 or more than 100, and it is usually ovoid with prominent nucleoli. This is how it looks like on microscopy. Now coming to the simple bone cyst, it usually present as a unilocular area in long bones like humerus, usually in the metaphyseal and epiphyseal region. Here it will be filled with fluid. On microscopy also you can find a fibrous wall without epithelium. Cyst will be lined by a fibrous wall without epithelium, and it will be filled with fluid which might resemble odontogenic cement. So here it might just be a fluid filled area, straw colored fluid filled area resembling as proteinaceous area of the lumen, eosinophilic proteinaceous lumen filled area, and here you won't find any epithelial lining or any bony fragment inside the cyst. But sometimes macrophages, giant cells can also be found in the lumen of the cyst. But aneurysmal bone cyst is a tumor characterized by multiloculated blood-filled cystic spaces. So that's how you differentiate a simple cyst from an aneurysmal bone cyst. Simple cyst is unilocular, whereas aneurysmal bone cyst is multiloculated blood-filled cystic spaces. It is also called as blue bone tumor and is included under tumors of unknown origin. Radiographically, typically ABC can also be seen as a radiolucent area, and usually it involves the metaphysis of the long bones and the posterior elements of the vertebral bodies. It affects all age groups, but it is usually seen in the first 2 decades of life. The most common symptom is pain and swelling, and when it involves the vertebrae, it can compress the nerves, causing neurological symptoms as well. If the patient is having GCT and chondroblastoma, they can be predisposed to secondary ABC as well. And coming to the pathogenesis of aneurysmal bone cyst, I just want to mention that the spindle cells of the ABC frequently demonstrate rearrangement in the chromosome 17, which chromosome 17 rearrangement result in fusion of coding region of USP6. So USP6 is nothing but it encodes a ubiquitin specific protease, USP, ubiquitin specific protease. So this protease regulate the activity of NFK beta. NFK beta is a transcription factor. So this transcription factor, it upregulates the matrix metalloproteinases, leading to cystic resorption of bone. So matrix metalloproteinases are nothing but enzymes which will cause degradation of the matrix. So this matrix metalloproteinases are increased because of transcription factor NFK beta. NFK beta, where is it coming from? Because of rearrangement or ubiquitin specific protease that is overexpressed here. So activity of NFK beta also increases. Microscopically, we see plump uniform fibroblasts. Okay, plump fibroblast will be there along with giant cells. So it might resemble osteoclastoma, but not exactly. It is not osteoclastoma because there won't be uniform spacing of the giant cells in the aneurysmal bone cyst, and there will be large areas of hemorrhages and dilated vessels in the aneurysmal bone cyst. Reactive woven bone can also be seen, which will be lined by osteoblast. 1/3 of the cases contain densely calcified matrix, which is called as blue bone. You cannot find necrosis in aneurysmal bone cyst. Now coming to the lesions simulating primary neoplasms, fibrous cortical defect and non-ossifying fibroma and fibrous dysplasia comes under bone tumor mimicking lesions. So fibrous cortical defects, which is also called as metaphyseal fibrous defect, is extremely common, and it is present in 30 to 50% of children older than 2 years of age. Vast majority, it arises eccentrically, mostly near the cortex and in the metaphyseal region of distal femur or proximal tibia. It is mostly bilateral and multiple. Mostly the fibrous cortical defect is 0.5 centimeter in diameter, and if it goes beyond 0.5 and reaches the size of 5 to 6 centimeter, it is also called as non-ossifying fibroma. So on X-ray, it is an incidental finding on X-ray and is usually asymptomatic, and it can undergo spontaneous resolution as well within several years. If it enlarges, it is called as non-ossifying fibroma and may lead to pathological fractures in adults. So both fibrous cortical defects and non-ossifying fibroma produce elongated, sharply demarcated radiolucencies that are surrounded by a thin zone of sclerosis. So this is how a radiolucent area surrounded by a thin zone of sclerosis can be seen. Microscopically, what we see here is fibroblasts and macrophages. So spindle-shaped fibroblasts arranged in fascicles can be seen along with giant cells. So macrophage can accumulate to form the giant cells, This might give a picture of osteoclastoma, but it is again not osteoclastoma, because in osteoclastoma the stromal cells will be mononuclear ovoid in shape, polyhedral to ovoid in shape, and the giant cell spacing will be uniform. Here we are seeing that the giant cells are scattered here and there, and the stromal cells are spindle shaped, not ovoid or polyhedral. So if it is spindle shaped and arranged in the form of fascicles or bundles, it is mostly fibrocortical defect or non-ossifying fibroma rather than osteoclastoma. Now coming to the fibrous dysplasia. So non-neoplastic condition, and it is of two types, monostotic variety and polyostotic variety. Monostotic variety is more common in older children and young adults and may involve rib, femur, tibia and skull. Polyostotic variety is usually common unilateral distribution associated with endocrine dysfunction, precocious puberty in females, and areas of cutaneous hyperpigmentation, which is called as McCune-Albright syndrome. Now the lesion is readily recognized radiologically by its typical ground glass appearance and well-defined margination. So now if it is involving mostly the humerus here and looks like polyostotic type of fibrous dysplasia. Now there are two types of syndrome associated with it, that is Maza-Proud syndrome and McCune-Albright syndrome. Maza-Proud syndrome is fibrous dysplasia and soft tissue myxomas. McCune-Albright syndrome is polyostotic disease associated with cafe au lait skin pigmentation, endocrine abnormalities, especially precocious puberty. The pathogenesis here is the result of gain of function mutation during development of GNAS1 gene. This GNAS1 gene is responsible for the production of active GS protein. This GS protein promotes cellular proliferation. So what happens here is mutation during embryogenesis produces mutation in this GNAS gene, which might affect osteoblastic precursors during the formation or after the formation of the skeleton, resulting in this fibrous dysplasia. The lesions of fibrous dysplasia are well circumscribed, intramedullary, and greatly vary in size, and it can produce tan white gritty lesions. Microscopically, it is composed of curvy linear trabeculae of woven bone. Okay, Chinese letter pattern will be there. Curvy linear pattern or Chinese letter pattern of woven bone, surrounded by moderately cellular fibroblastic proliferation. So these curvilinear shapes of trabeculae mimic the Chinese character, and the bone lacks prominent osteoblastic rimming. So osteoblastic rimming, where did we see? Osteoblastoma and osteoid osteoma will have osteoblastic rimming, but here fibrous dysplasia won't have osteoblastic rimming. So this will differentiate a fibrous dysplasia from osteoid osteoma or osteoblastoma. Sometimes you can see nodules of hyaline cartilage as well. Cystic degeneration, hemorrhage, foaming macrophages are also a common finding. So this is how a woven bone will look like. It won't have this cuboidal or flattened osteoblastic rimming as we have seen in osteoid osteoma. Fibrous dysplasia might be complicated by malignancy, mostly the sarcomas. So it can convert into osteosarcoma, chondrosarcoma, or malignant fibrous histiocytosis. And treatment is usually surgical curettage and repair of the fracture. So coming to summary, I just want to emphasize the location of the tumor, mostly whether it is epiphysis, metaphysis or diaphysis. So in the epiphysis, you should remember that osteochondromas, giant cell tumor, chondroblastoma, osteomyelitis of the fungus and TB, and aneurysmal bone cyst can occur in the epiphysis. Whereas fibrosarcoma, chondromyxoid fibroma, some type of aneurysmal bone cyst, enchondroma, medullary enchondroma, simple bone cyst, fibrous dysplasia, and pyogenic osteomyelitis mostly involves the metaphysis. Fibrous cortical defects, osteochondromas, osteosarcomas can arise from the metaphysis. Coming to the diaphysis, round cell tumors, fibrous dysplasia, adamantinoma, osteoid osteoma, stress fracture and chronic osteomyelitis can arise from the diaphysis. From the center of the diaphysis, fibrous dysplasia can arise. Again from the central part of the metaphysis, enchondroma, simple bone, fibrous dysplasia can arise. Fibrosarcoma can also arise from the intermedullary area. So this completes our topic on bone tumors and bone tumor-like lesions. If you have any doubt, please mention in the comments. I'll be happy to clarify. Thank you.